Hello, everybody. Today we are going to discuss this article about physiologically difficult airway. So, the difficult airway has been traditionally been used in reference to the anatomical airway characteristic, rendering the successful placement of endotracheal tube difficult for the experienced practitioner. So as we all have experienced, the cardiac arrest occur in as many as 3.1% of endotracheal intubated patient, of whom 47.3% do not achieve the spontaneous circulation. And the patient at high risk of tracheal post intubation hypoxemia or with the hemodynamic collapse can be thought of having physiologically difficult airway, where despite reassuring airway anatomy, safely securing the airway remains difficult due to ongoing physiological derangement. So now we'll see the factors which are responsible for the physiologically difficult airway. So first is hypoxemia. Hypoxemic respiratory failure is commonly encountered indication for tracheal intubation. And this state is associated with ventilation perfusion mismatch, impaired gas transfer and diffusion, and physiological and anatomical shunt, where blood does not adequately participate in alveolar gas exchange before entering systemic circulation. And the common culprit conditions for this include pneumonia, atelectasis, ARDS, pulmonary edema, and mucus plugging. And the comorbidities like obesity and impaired level of consciousness is associated with reduced functional residual capacity, which further reduce the respiratory reserve. So these factors are acutely worsened with the induction of anesthesia, which we are using for the tracheal intubation, resulting into the increased risk of potentially life-threatening tracheal intubation-related complications. Now, the first factor the first intervention that we need to do to reduce the incidence of the hypoxemia is pre-oxygenation. So we should optimally pre-oxygenate the patient if we know that it is going to be physiologically difficult. So pre-oxygenation with the non-rebreather mask, both the effective seal and set at flush flow rate of 50 to 70 liter per minute has been shown to be non-inferior to the pre-oxygenation with the back mask ventilation at flush flow rate of 50 liter per minute. So in case of ineffective seal, we can add nasal cannula at the rate of 10 liter per minute to whatever primary method we are using. Either it is non-breather mask or a bag mask ventilation. So the another thing that we need to consider while pre-oxygenating patient is to give the head up position at least at 20 to 30 degree to increase the functional residual capacity. And this intervention may be balanced against the patient's hemodynamic condition and their ability to tolerate this position. So the pre-oxygenation with the NIV is recommended for patient with the shunt physiology and has been associated with the reduced peritracheal intubation hypoxemia compared to non-rebreather mask. And the pre-oxygenation with the high flow nasal oxygenation is shown non-inferior to the NIV in preventing desaturation when left in place for apneic oxygenation. So patient with the oxygen saturation less than 93%, not responding to the above technique are likely to have significant shunt physiology. So in this case, NIV is using either mechanical ventilator or manually assisted bag mask ventilation using 5 to 10 centimeter of PEEP is logical next step in escalating pre-oxygenation method as it reduces the ventilation perfusion mismatch and improves the FRC. So this hypoxemia can be graded according to the PaO to FiO2 ratio, and according to that we can choose the device. Like if the PaO to FiO2 ratio is less than 300, then we can go for either bag mask ventilation and high flow nasal oxygenation. NIV for the FiO2 PaO2 ratio of 200 to 100, and if it is a less than 100 and if it is a refractory hypoxemia, then go for the awake intubation. Now the next is apneic oxygenation. Apneic oxygenation is the application of supplemental oxygenation without using positive pressure, typically via nasal canal. So the some amount of the gas exchange is achieved via dead space flushing and turbulent gas mix. So we can achieve this by using standard nasal cannula at the 10 to 15 liter per minute and is effective at prolonging time of desaturation. So we can also use the newer high flow oxygenation device which deliver the heated and humidified oxygen at the rate of 40 to 70 liter per minute. So this high flow nasal oxygenation will reduce the rate of carbon dioxide accumulation to the greater extent than the standard nasal cannula. The combination of the NIV for pre-oxygenation and the high flow nasal cannula for apneic oxygenation has been shown to maintain oxygen saturation greater than NIV alone for patients with a severe hypoxia. Now the next is refractory hypoxia. Anxious and the delirious patient may be unable to tolerate pre-oxygenation. In such a cases, non-respiratory depressant sedative like ketamine can be considered prior to the pre-oxygenation to improve patient compliance and the effectiveness of the pre-oxygenation. Cautious pharmacological titration is warranted with this approach to avoid apnea that can occur even with small sedative dose. In patients with the dramatically altered gas exchange and FRC, rapid desaturation may occur the moment supplemental oxygenation and ventilation are removed. So, the recommended approach is awake tracheal intubation, maintaining oxygenation and spontaneous ventilation during intubation process. So, regarding rapid sequence intubation versus bag mask. A recent study compared the use of bag mask ventilation during the apneic interval between the induction and the anesthesia and tracheal intubation to traditional rapid sequence intubation without bag mask ventilation in critically ill patients. So what they have found is bag mask ventilation resulted in higher oxygen saturation and reduced incidence of desaturation to less than 80%. This trial also suggests that bag mask ventilation may be more effective than apneic oxygenation at maintaining oxygen saturation in critically ill. The study, however, was not designed to evaluate safety outcome and notably tracheal aspiration. And the patient with obvious contraindication to bag mask ventilation were excluded from the study. So, point of care ultrasound may help to clarify the etiology of hypoxemia and guide the therapy. Now we will see, we'll have a look on this table uh, and which clarifies the strategies for optimizing hypoxemia. So as we have already seen, the first strategy is pre-oxygenation. For pre-oxygenation, we can use high flow nasal cannula, NIV, and we can also use the inhaled pulmonary vasodilator. So this the choice of device should be based on the PO to FiO2 ratio. If PO to FiO2 ratio is between 300 to 200, then we can go for high flow nasal cannula. So and if the PO to FiO2 ratio is between 200 to 100, then we can use the NIV. So the advantage of the NIV, it will reduce the peri-intubation hypoxemia compared to the non-rebreather mask and the bag valve mask. It reduces the ventilation perfusion mismatch. It improves the work of breathing. So we can also use inhaled pulmonary vasodilator to improve oxygenation by reducing ventilation perfusion and have a role in pre-oxygenation optimization. Now, the next strategy that can be used is apneic oxygenation. Apneic oxygenation can be delivered with a standard nasal cannula at the flow rate of 10 to 15 liter per minute, and it is shown to prolong time to desaturation and it provides the unpredictable level of gas exchange. For apneic oxygenation, we can also use high flow nasal oxygen cannula, which provide the flow of 40 to 70 liter per minute. It has shown to significantly prolong time to desaturation in operating room. It reduces the rate of CO2 accumulation in dead space flushing to greater extent than standard can. the physiological basis for improved performance compared to standard nasal cannula. Now, regarding refractory hypoxemia, the high risk for the severe apnea tolerance. Consider in case of refractory hypoxemia, where PO to FiO2 ratio is less than 100, consider awake spontaneous breathing intubation strategy. Other optimization is the point of care ultrasound may clarify etiology, diagnose treatable conditions such as pneumothorax, pulmonary edema, pleural effusion, pulmonary embolism, cardiac dysfunction. Pulmonary vasodilator reduces the ventilation perfusion mismatch and reduces the right ventricular out, right ventricular after. So now the next physiological derangement that we need to consider and which contribute to the physiologically difficult airway is hypotension. So the patient requiring mechanical ventilation often presents with the hypotension. So the cause of hypotension is the distributor hypovolemic shock, which is associated with a decreased venous return, and it is exacerbated by giving the anesthetic induction agent and the muscle reaction with abrupt transition to the positive pressure ventilation. So the pretracheal intubation hypotension is defined as systolic blood pressure less than 90 mmHg, and it is if and in this case they are the and it is associated with 12% to 15% incidence of peritracheal intubation cardiac arrest, of which return of spontaneous circulation will be achieved only in 53% of the patient. So the peritracheal intubation cardiac arrest carries 14-fold increased risk of hospital mortality. The shock index, which is calculated by heart rate upon systolic blood pressure, if it is more than zero point 0.8, then it is independently associated with increased risk of peritracheal intubation cardiac arrest. Every 10 minutes of hypotension can result in poor outcome for high-risk patients. So we will see what are the methods to deal with this hypotension. So the first is volume administration. So administration of up to 500 ml of the crystalline bolus prior to the tracheal intubation has been shown not significantly alter the rate of peritracheal intubation cardiovascular collapse. A more physiological approach is to administer fluid to the patient who are volume responsive. Volume responsiveness can be evaluated using the bedside technique, including arterial waveform analysis, focus assessment of inferior vena cava, respiratory variation, and passive leg raising test. Now, the next method is vasopressor and inotropic support. In hypotensive patient, unresponsive or intolerant to the fluid administration, prophylactic vasopressor and inotrope infusions are recommended. So, when unable to initiate infusion, bolus dose vasopressors and inotrope should be immediately available and used to support hemodynamics during tracheal intubation. The choice of the agent choice should be tailored to the individual patient and suspected hypotension etiology. Now, regarding the choice of induction agent. The majority of anesthesia induction agent may acutely worsen hypotension in critically ill patients. So propofol and benzodiazepines lead to the myocardial depression and vasodilation. So propofol administration has been independently associated with hemodynamic instability in emergency tracheal intubation. So the alternative agents for this is ketamine and etomidate. But as we look into the literature, there is a mixed opinion regarding the safety of etomidate. And also with the help of with etomidate, there are concerns regarding adrenal suppression, and some studies have shown no harm when using solely for induction. So when ketamine and etomidate have been compared directly, then the results were etomidate versus ketamine trial showed that patient induced with the etomidate have higher risk of 7-day mortality compared to ketamine, but the risk converged to the similar to the overall mortality at 28 days. And interestingly, the ketamine had the had a greater association with post-induction cardiovascular collapse compared to the intermediate. That is, with ketamine, the incidence of post-induction cardiovascular collapse was 25%. With intermediate, it was 17%. Also, ketamine was associated with laryngospasm, airway secretion, myocardial depression, myocardial ischemia, and cardiac arrest. With the help of focus, we can identify the important physiological variables in hypotensive patient, including presence of left ventricle, right ventricle dysfunction, significant valvular abnormalities, pericardial effusion, fluid responsiveness, and tolerance. So this is this table. In this table, they have summarized the recommendation of how to deal with the hypotension. So first is volume administration, clinical evaluation of the volume status, and intravenous fluid administration to volume responsive patients should be done. Then the next is the use of the vasopressor and the inotropic support. Vasopressors and the inotropic infusion bolus dose should be immediately available when intubating critically ill patient. Selection of specific agent should be tailored to the patient presentation. Then regarding induction agent, propofol is independently associated with hemodynamic instability in emergency intubation. And the lack of definitive evidence for superiority of the ketamine or etomidate when directly compared. Induction agent should be chosen and dosed based on the clinician comfort and the patient factor. The point of care ultrasound may help guide peri-intubation resuscitative efforts and hemodynamic optimization. Now, other physiological derangement that need to be considered is severe metabolic acidosis. Severe acidosis can cause seizure, coma, arrhythmia, and cardiac arrest. The risk is particularly elevated at arterial pH of less than 7. While if it is respiratory acidosis, it can be improved with ventilation. But metabolic acidosis can be severely worsened during the peritracheal intubation period. So, the patient with metabolic acidosis often hyperventilate in an effort to normalize their pH. So, even brief apneic period can cause carbon dioxide accumulation, will further lower the pH, thereby potentially triggering the cardiac arrest. Now, the optimization of the metabolic acid. In patients with the severe metabolic acidosis, NIV may be used to assess ventilation and pre-oxygenation and to measure respiratory parameter predicting the required minute ventilation. In severe cases, it is possible that high minute ventilation requirement may not be achievable by mechanical ventilator. In these cases, intubation should be avoided or delayed when possible, and NIV used to support hyperventilation until treatment of underlying cause of acidosis is initiated. When intubation cannot be delayed, maintenance of spontaneous respiration during intubation and after intubation should be considered. So some authors suggest to avoid RSI technique or using short-acting neuromuscular blocker agent when RSI is required. High flow nasal oxygenation for apneic oxygenation can slow accumulation of carbon dioxide via dead space flushing. Induction agent should be chosen and carefully titrated to avoid further hemodynamic deterioration. After intubation, supported spontaneous ventilation strategy should be considered to allow patient to set their minute ventilation and maintain the respiratory compensation. Now, in this case, care should be taken to avoid air trapping given the high tidal volume and respiratory rate this patient often requires. So we will see this table where it will summarize the recommendations for peri-intubation optimization of metabolic acidosis. So the first is delay intubation. Ideally, we should delay the intubation until the underlying cause of acidosis is treated. Now, the second one is the use of NIV. It improves the pre-oxygenation and peri-intubation gas exchange. It provides the guidance for post-intubation ventilation requirements. Then the third one is awake intubation. It allows the maintenance of spontaneous respiration and gas exchange to prevent the worsening of acidosis with apnea. It also allows for supportive mode of ventilation immediately post intubation, preserving respiratory compensatory drive. Then the fourth one is apneic oxygenation. It may provide unpredictable amount of gas exchange during apneic period. Then the last one is peri-intubation bicarbonate boluses. There is not much evidence for this, and it is the ongoing subject of debate. The other physiologically difficult airway are hypoxia, hypotension, acidosis are the common presentation associated with the physiologically difficult airway. And the some clinical critical condition are presented below. So the first condition is RV failure. The failing RV is the sensitive to the changes in preload and afterload during tracheal intubation. So the hypotension secondary to the induction agent and increased thoracic pressure from mechanical ventilation can both lead to reduced venous return and RV preload. Hypoxia, hypercarbia, increased sympathetic tone, and tracheal intubation induced increased intrathoracic pressure can increase RV after. So, intubation strategies should be chosen to avoid hypoxia, hypercarbia, acidosis, sympathetic stimulation, and hemodynamic instability. Now, the next condition where intubation can be difficult is cardiac tamponade. Cardiac tamponade results in elevated LV filling pressure, impaired diastolic filling pressure, resulting into the fixed stroke volume, thus rate-dependent cardiac output, which may deteriorate further with reduced preload, systemic vascular resistance, and increased intrathoracic pressure, which occur during tracheal intubation. So, whenever the tracheal intubation is required, strategies should be tailored to preserve spontaneous ventilation, augment or maintain preload, avoid bradycardia, maintain sinus rhythm, maintain systemic vascular resistance, maintain cardiac contractility, and minimize the increase in intrathoracic pressure. Now, the next condition that is associated with the physiologically difficult airways, aortic stenosis. Patients with the severe aortic stenosis have the fixed obstruction to the LV outflow, resulting into the impaired ability to increase the cardiac output to compensate for physiological stress, particularly systemic vasodilation. LV hypertrophy and diastolic dysfunction result in increased myocardial oxygen demand and tenuous oxygen supply, which may result in myocardial ischemia and rapid hemodynamic deterioration on induction of anesthesia and tracheal intubation. So, the adequate preload and LV filling pressure maintain the low normal heart rate to allow diastolic filling and coronary perfusion, maintain sinus rhythm, maintain contractility, maintain elevated systemic vascular resistance to increase the coronary perfusion. Now, the next condition which can result in physiologically difficult airway is mitral stenosis. So, stenotic mitral valve impair the LV diastolic filling and increase the left atrial, pulmonary arterial, and RV pressure, eventually resulting in arrhythmia, pulmonary edema, pulmonary hypertension, and RV. So, in the intubation strategy in this case is tailored to maintain the low normal heart rate to maximize LV filling time, maintain the hemodynamic stability, avoid atrial fibrillation, maintain euvolemia, and avoid precipitating RV failure. Now, the next condition that can result into the physiologically difficult airway is hypermetabolic state. Hypermetabolic state, such as seen in sepsis, thyrotoxicosis, acute respiratory distress syndrome, burn patient, results in elevated oxygen consumption, elevated carbon dioxide accumulation, thus impaired apnea tolerance. And the ideal strategies are optimal pre-oxygenation, apneic oxygenation, and awake intubation. So we'll see this table which summarizes the peri-intubation goal in different conditions. Like if the patient has right ventricular failure, then optimize the right ventricular afterload by avoiding hypercapnia, by avoiding hypoxemia, avoid acidosis in this case, avoid sympathetic stimulation, avoid high intrathoracic pressure, and consider inhaled pulmonary vasodilators. Ensure hemodynamically stable induction. Practice careful fluid management, ideally guided by point of care ultrasound. If there is a cardiac tamponade, then augment and maintain preload, avoid bradycardia, maintain sinus rhythm, maintain systemic vascular resistance, minimize increase in intrathoracic pressure. In case of aortic stenosis, maintain preload, low normal heart rate, maintain sinus rhythm, maintain systemic vascular resistance, coronary perfusion pressure, and maintain U volume. Regarding mitral stenosis, maintain low volemia, low normal heart rate, maintain sinus rhythm, aggressively treat arrhythmias, optimize the right ventricular afterload. And in case of hypermetabolic state, which was the high risk for rapid desaturation, consider treating as severe hypoxemia. Thank you, friends.